Hello, I'm Nancy Rowe from Rush University Medical Center and the current chair of the Hepatology Interest Group for WGO. I'm here to open the webinar on the global burden of viral hepatitis, breakthroughs in hepatitis B. This symposia has been put together in honor of World Hepatitis Day and in efforts to achieve world elimination of viral hepatitis. Today's speakers and topics include Professor Tato Marinho from Portugal, Professor Ebada Said from Egypt, and Professor Suna Yapali from Turkey. Please enjoy.
Hello, everybody. My name is Rui Marinho. I'm coming from Portugal. I'm a gastroenterologist and hepatologist and the director of the National Program for Viral Hepatitis at the Ministry of Health of Portugal. I work in a big hospital, the biggest one in Portugal, Hospital Santa Maria in Lisbon. I'm going to talk about how to push for universal screening and vaccination updates. Some facts and figures. One of the most important Nobel Prize is Baruch Blumberg. On the subject of hepatitis B in 1976. His work has saved a lot of lives, beginning the research in the field, for example, in Australia, and it has been possible throughout these years to have good tests, marvelous vaccine, treatment for control, not for cure, and it has been possible to save a lot of lives. Continuing with the facts and figures, some from the WHO. It's incredible, the 300 million chronic carriers throughout the world, 1.5 million new infections each year, almost 1 million deaths each year for double cause cirrhosis and cancer. Hepatitis B virus is a silent one, leading to a silent disease, and I call it a silent liver. If the infection begins before 5 years old, almost 100% will become chronic care throughout all this life. But we have excellent tests, excellent vaccine, and won a Nobel Prize in 1976. And if hepatitis B is becoming chronic, there is no cure. It's possible to control with antiviral drugs, oral antiviral drugs, but it's not possible to have a cure like hepatitis C. The field of hepatitis, the amazing field of hepatitis, are not only letters. We know, everybody knows A, B, C, D, E, and some unknown causes, but we should see not only letters, but people with cancers, people dying, people with cirrhosis beside the letters. That's liver. It's liver in the terminal period with leading to ascites, vomiting of blood, varicose bleeding, encephalopathy, coma, people with hemorrhage, and of course, hepatocellular carcinoma, the tumor of the liver, and cirrhosis. That's cirrhosis. Cirrhosis is a liver with an irregular surface, very hard if we palpate this liver. So this liver is not in good condition. This is cirrhosis. As you can see, a lot of nodules in the surface of the liver. It's a complex situation, liver disease, leading to cirrhosis, hepatocellular carcinoma, one of the main tumors of the world, if possible, transplant, the world of palliative care and suffering, and it's one of the most important causes of death. If one gets cirrhosis from hepatitis B or hepatitis C, the risk of hepatocellular carcinoma, the risk of liver cancer is 10 to 40% each decade. So it's like a sword above our head if you get cirrhosis, even compensated cirrhosis, even a silent cirrhosis. Nobel Prize, magnific vaccination programs, excellent vaccine, but only half of the countries in the world, after 50 years of research, only 56% has the hepatitis B birth dose vaccination strategy in the national immunization program. Is one of the most effective, perhaps the most effective measure to control worldwide hepatitis B. Only a small amount of countries with the first dose in the first day after birth. Portugal is one of them in the last 20 years. So we are not seeing any more new cases from hepatitis B in the Portuguese population. So one of the most important measures is to give one shot 24 hours after birth. Perhaps is a top measure. Some countries has adopt this policy. After some years, the prevalence of the chronic carrier in children went from 10% to 1% in 4 or 5 years. There are some countries who have adopted the immunization for all infants to prevent, for example, liver cancer, and the vaccine is anti-cancer vaccine. It's more effective than chemotherapy, for example. As you can see in this work from Taiwan, the people who got the vaccination for hepatitis B, the number of liver cancers decreased in comparison with the children we don't get the vaccine. So vaccination for hepatitis B is a measure anti-cancer, anti-hepatocellular carcinoma, one of the worst cancers in the world. For example, it's amazing to see the work done in Alaska, published in Hepatology 2011, that 25 years after beginning the immunization program for newborn, it was possible, as like in the other works that I have shown, to decrease the prevalence of HBsAg in children in 20 years from 1.2%, for example, to 0%. So vaccination reduces the prevalence of the chronic carriers. Vaccine reduces the prevalence of liver cancer in children, for example. It's also a work from Alaska. So considering these huge facts and figures and the effectiveness of the very good vaccination and the strategy proposed, and considering some innovation also in this area, we have a new vaccine for hepatitis B, already approved by European Medicines Agency and the FDA in the United States. And this vaccination is very effective, and we need only 2 shots. A new recommendation coming from the CDC is that, considering the very effective vaccine without side effects, almost without side effects, that the people in countries it is possible to do that all adults aged 19 through 59 years should receive the vaccination, even if they think they are not a risk population for getting hepatitis B. So we recommend, if it is possible, to amplify the group of people vaccinated against hepatitis B, even without the so-called risk factors, even in adults. So, concluding my presentation and considering the main objectives of presentation, to push for universal screening and vaccination update, I would recommend test once in life for hepatitis B or hepatitis C or HIV with one small amount of blood. We can test for 3 viruses with medical intervention, vaccination, cure, for example, hepatitis C and control the hepatitis B. Top priority to vaccinate at birth in the first day. Perhaps the most important measure to control worldwide hepatitis B. Push for vaccination in adults until 60-year-old or older, if we have money or we want to do that. There is a new HPV vaccine needing only 2 shots, not the 3, approved by FDA and EMA. And the vaccination against hepatitis B. There is also one formula with including hepatitis A antigen, and the vaccination against hepatitis B prevents also hepatitis delta, and in my point of view is the first vaccination anti-cancer leading to decreased numbers of hepatocellular carcinoma. Finishing, I'm inviting you to come to Portugal in 2024 in Lisbon, Portugal, for the World Hepatitis Alliance Summit with the collaboration of World Health Organization. And Portugal is Lisbon is a sunny place with nice monuments by the river. So come to Portugal 2024.
Dear colleagues, it's a great pleasure for me to participate in this World Gastrology Organization activity about hepatitis B. I am Ebada Saeed, Professor of Hepatogastroenterology, Marinho University, Egypt. My topic will be about hepatitis B indications for treatment and potential areas for expansion. My agenda will be about natural history, when to treat, whom to treat, when to start, and potential expansions. Bloomberg was awarded the Nobel Prize in Medicine for discovering the causative agent of hepatitis B in 1967. It was discovered in Australian Aboriginal serum, hence it was called the Australia antigen. It's a small double-stranded DNA virus of the family Hepatnaviridae that integrates into the host genome and may be incorporated in the occurrence of cirrhosis and hepatocellular carcinoma, as well as fulminant hepatic failure. The worldwide prevalence is between 2 and 8%, and my country is lying in between in the intermediate zone, but towards the 2% level. The availability of safe and effective vaccines and several approved treatments have made hepatitis B a preventable as well as a treatable condition. The incubation period of hepatitis B is around 75 days, varies from 1 to 6 months. Acute hepatitis B can be asymptomatic or present with the classic manifestations of acute hepatitis. The risk of acute hepatitis to become chronic varies inversely with the age at which acute infection occurs. 90% of HBV chronicity from perinatal acquired infection, while only 5% chronicity for adult acquired HBV infection. The risk of progression to cirrhosis and HCC is affected by the host's immune response as well as the viral factors. The annual risk of HCC in patients with cirrhosis has been reported to be 2 to 5%. The risk for developing, as I mentioned, hepatocellular carcinoma is dependent on factors related to the host like cirrhosis, chronic hepatic inflammation, older age, male sex, African origin, alcohol abuse, chronic co-infections with other hepatitis viruses or HIV, presence of diabetes or metabolic syndrome, active smoking, positive family history, and those related to the HBV properties like high HBV DNA levels or HBV S antigen levels, HBV genotype C more than B, and specific mutations. All the factors seem to affect the progression to cirrhosis in untreated chronic hepatitis B patients. Hepatitis B infection is a dynamic process reflecting the interaction between HBV replication and the host immune response. Not all patients with chronic hepatitis B infection have chronic hepatitis. This is a summary of the recent guidelines. Several guidelines do exist, like the ASLD guidelines that were published in 2015 and updated in 2015, EASL guidelines in 2017, APASL guidelines was published in 2016, and the Korean guidelines that were published in 2019. Here, the difference relies on the enzyme levels. The EASL and the APASL consider 40 units per liter as a standard for both males and females, while the ASLD considers the upper limit of normal is 635 for males and 25 for females. For simplification, dependent on the cutoff values of the hepatitis B viremia, we consider the level of 2,000 international units per liter and 20,000 international units per liter as cutoffs regarding the presence of hepatitis B E antigen positivity or negativity. And the enzyme level is considered to be treated when it is more than 2 upper limit of normal. This if the patient is with hepatitis B E antigen positive, with viremia more than 20,000 international units per liter, and with enzymes elevated more than double the upper limit of normal, treatment is considered. If he is hepatitis B E antigen negative with 2,000 only hepatitis viremia and the upper limit of normal is double, its treatment. According to the different guidelines, patients may lie in several groups according to the natural history. The ASLD differentiate them into chronic hepatitis B, immune tolerant, immune active, and inactive chronic hepatitis B carrier, while the EASL categorized them into 5 phases, taking in the account the presence of HBe antigen positivity, HBe DNA levels, ALT values, and eventually the presence or absence of liver inflammation. The phases of chronic hepatitis B virus infection are not necessarily sequential. EASL's nomenclature is based on the description of the 2 main characteristics of chronicity, infection versus hepatitis. This table simplifies and differentiates the definitions of EASL and ASLD. Those with the dark blue columns that necessitate initiation of treatment at once. Others may mandate the delay of treatment with follow-up. Treatment. Why to treat? To improve the quality of life and survival by preventing disease progression to cirrhosis and HCC, and to treat HBV-associated extrahepatic manifestations like glomerulonephritis, vasculitis, polyarteritis nodosa, and peripheral neuropathy. Second, to prevent transmission, either vertically from mother to child or the community, and to prevent the hepatitis B reactivation when a transient immune suppression is expected. Aim of treatment is induction of long-term suppression of HBV DNA. We all know that the treatment of hepatitis B virus infection is not curable. It's a suppressive treatment, and the aim is to induce a long-term suppression of the virus, induction of HBe antigen loss with or without anti-HBe seroconversion in HBe antigen positive patients with chronic hepatitis B, which is named the immune reactive HBe antigen positive. The aim is to induce ALT normalization, which is termed the biochemical response, and to induce HBs antigen loss with or without HBs seroconversion, which is the optimal endpoint, I mean the HBs antigen loss. Who to treat? Decision is primarily based on the combination of 3 parameters: HBV DNA, serum ALT, and advancement of liver disease. Those who should be treated: patients with HBe antigen positive or negative chronic hepatitis B, defined by HBV DNA more than 2,000 international per milli, ALT is more than the upper limit of normal, and or at least moderate liver necroinflammation or fibrosis. Patients with cirrhosis should be treated with any detectable HBV DNA level, regardless of the ALT level. Patients with HBV DNA more than 2,000 international unit per milli and ALT above the double the upper limit of normal, regardless of the severity of histopathological changes. Decision is primarily based on the combination of 3 parameters, as I mentioned before: HBV DNA, serum ALT, and advancement of liver disease. Those who may be treated: patients with HBe antigen positive chronic hepatitis B infection, more than 30 years old, regardless of the severity of liver histological lesions. And those who can be treated: patients with HBe antigen positive or negative chronic hepatitis B virus infection and family history of HCC or cirrhosis and presence of extrahepatic manifestations, as I mentioned before. This diagram simplifies how to approach a patient with suspected HBV infection according to the presence of HBV surface antigen positivity, HBe antigen positivity, and presence or absence of cirrhosis. Treatment options: we have many drugs. The available ones and those who proved efficacy with less side effects are interferon, lamivudine, entecavir, tenofovir, disproxil fumarate, and lastly tenofovir alafenamide. Other drugs do exist, but with not such efficacy and less side effects. This is the Egyptian National Committee for Control of Viral Hepatitis protocol for the management of patients with HBV infection. I gave it as a for simplification. For special groups, that indication of treatment may be extended, like cases with acute infection. They should be treated when acute liver failure is impending or the presence of 2 out of the following 3 criteria: total bilirubin more than 10 mg per dl, INR more than 1.6, or encephalopathy. Treatment is at least for 6 months after seroconversion to anti-HBs antigen, or at least 12 months after seroconversion to anti-HBe without HBs antigen loss. Those with liver cirrhosis, as I mentioned before. Those with combined HBV-HCV infection, as HCV treatment with DAAs may cause reactivation of HBV. Patient with combined HBV-HIV co-infection. All HIV positive patients with HBV co-infection should start antiretroviral therapy irrespective of the CD4 cell count, or with tenofovir-based antiretroviral therapy. HBV-HDV co-infection, when confirmed by HDV RNA assay, peg interferon is the only effective drug against HDV. Start HBV treatment with any viral load. Optimal duration is at least 48 weeks. Pregnant women: all pregnant females should be screened for HBs antigen at the beginning of the 3rd trimester, if not measured before or screened before. Newly diagnosed pregnant women in the last trimester should have taken tenofovir fumarate. It's a class B drug once daily, starting from 24 weeks of gestation and for at least 3 months after delivery, then re-evaluate. Renal insufficiency patient: all patients on dialysis should be screened for HBV. Seronegative patients should be vaccinated. Entecavir is the preferred one. Those should be adjusted according to the creatinine clearance. For those who are immune suppressed patients, all candidates for immune suppression and chemotherapy should be screened for HBs antigen, anti-HBs antibody, and anti-HB core antibody prior to initiation of treatment. Vaccination is mandatory for seronegative cases. And treatment strategy is applied for those who need treatment. Liver transplantation: pre-transplant, all patients who are candidates for transplantation should receive nucleoside analogs to achieve undetectable HBV DNA and reduce the risk of graft infection. Post-transplant, combination of HBV immunoglobulin and a potent nucleoside analog is recommended to prevent HBV recurrence. HBV is antigen-negative patients receiving livers from donors with evidence of past HBV infection are at risk of HBV recurrence and should receive antiviral prophylaxis with the nucleoside analog. Immune tolerance. Defining true immune tolerant phase is challenging, and initiation of antiviral therapy for patients in the immune tolerant phase remains very controversial. Recent data regarding the treatment of chronic hepatitis B patients in the immune tolerant phase suggests that the risk of progression to liver cirrhosis and HCC development could be reduced by antiviral therapy. Cirrhotic patients, as I mentioned, most guidelines recommend treating compensated cirrhosis if HBV DNA level is at least 2,000 international per milli, regardless of ALT level. Furthermore, even patients with detectable with any level HBV viremia should be considered for treatment. In patients with decompensated cirrhosis, antiretroviral therapy should be initiated regardless of the ALT level if serum HBV DNA is detected. Preferably, all HBs antigen positive decompensated cirrhosis patients should receive antiviral therapy even if HBV DNA is not detected. However, the benefits of nucleoside analogs require further studies. Liver transplantation should be considered for those patients with decomposed HBV decompensated cirrhosis, of course. Healthcare workers constitute an important category with HBV infection. Cut-off levels of HBV viremia that necessitate treatment may be changed according to the society and the country. Take-home message: although several therapeutic agents have been approved and used for treatment of HBV infection, the disease remains difficult to cure. The goals of treatment are to improve health-related quality of life and survival by preventing the progression to cirrhosis and preventing hepatocellular carcinoma. The aims of anti-HBV treatment include ALT normalization, undetectable serum HBV DNA, serum HBe antigen loss or seroconversion, and serum HBs antigen loss or seroconversion, which is the optimal endpoint. To determine when to initiate antiviral treatment, the level of HBV replication by HBV DNA measurement and degree of liver injury measured by LAT or liver biopsy, and the stage of liver fibrosis assessed by non-invasive methods like FibroScan or liver biopsy should be considered. Additionally, information regarding age, comorbidity, family history of HCC or liver cirrhosis may be helpful in determining when to start treatment. Thank you very much.
Hello, I'm Dr. Suna Yapali from Turkey. I'm an associate professor at Acıbadem University in Istanbul. In this Breakthroughs in Hepatitis B webinar, my topic is stopping rules and risk for relapse. The main goals of antiviral therapy in chronic hepatitis B is to improve survival and quality of life by preventing progression to cirrhosis, liver failure, and hepatocellular carcinoma. Nucleoside analogs have excellent tolerance and safety profile, and they are potent inhibitors of HBV DNA replication and do not result in cure. The endpoints used in the assessment of efficacy are HBV DNA suppression, ALT normalization, e-antigen seroconversion in E-positive patients, histological improvement, and/or regression of fibrosis. However, the ideal endpoint is HBs antigen seroclearance with undetectable HBV DNA, which is the definition for functional cure. But functional cure is a remote goal, and it can be achieved in 5 to 10% of e-antigen positive patients and only in less than 1% of e-antigen negative chronic HBV. Therefore, lifelong nucleoside analog therapy is generally required. Then we know that the patients on nucleoside analogs are on long-term viral remission. Then why should we consider stopping treatment? Because of the concerns for long-term safety, especially in elderly patients with comorbidities such as chronic renal insufficiency, or diabetes. Treatment adherence may pose a problem in the young population, the cost of treatment, and family planning issues in patients of reproductive age. On the other hand, there can be unpredictable worsening of disease when we stop the treatment, the risk of fulminant hepatitis, acute on chronic liver failure, and risk of developing resistance by stop and start treatment. The recommendations of guidelines for patients with cirrhosis are clear. All patients with cirrhosis require lifelong treatment and should not discontinue antiviral therapy because of the risk of HBV reactivation, which can cause acute on chronic liver injury. Let's have a look at the recommendations of guidelines for non-cirrhotic patients. In e-antigen positive patients, if e-antigen seroconversion is achieved after completion of 12 months of consolidation treatment with undetectable HBV DNA and normal ALT levels, treatment can be stopped. And a puzzle guideline also recommends to extend the consolidation treatment to 36 months. In e-antigen negative patients, all the guidelines recommend lifelong treatment. And also treatment can be stopped after S antigen loss is achieved. In a puzzle guideline, because of the cost of lifelong treatment, after treatment for at least 2 years with undetectable HBV DNA documented on 3 separate occasions 6 months apart, treatment stopping can be considered. And also at EASL guideline, in selected non-cirrhotic e-antigen negative patients who have achieved 3 and more years of virological suppression under nucleoside analogs may also be considered to stop treatment. And these patients should be monitored, and close monitoring should be guaranteed. And what happens after stopping treatment? Does stopping treatment increase immune control? After stopping treatment, generally there is a lag period which changes between 1 to 3 months, and we can see HBV DNA flare followed by ALT flare, and relapse of HBV replication after stopping treatment may alter the phenotype of HBV-specific T cells. And also, on nucleoside analog treatment, the exhausted CD8 positive T cells may acquire their properties on the immune control, and they can also restore their functions. So in the end, what happens when we stop the treatment? Some patients may become active chronic hepatitis B and may require retreatment. Some patients may remain in an indeterminate phase, and some patients may have viral remission with normal ALT levels, mimicking a true healthy carrier state. And some patients may achieve functional cure with S antigen loss, generally at a 20% rate after 2 to 3 years. So what about the studies in stopping the treatments? This is a systematic review of 25 studies, mainly from Asia, including 700 patients. In e-antigen positive patients, 36 months after stopping treatment, viral remission is 50%. And when they examined the durable e-antigen seroconversion, it was 88% 24 months after nucleoside analog discontinuation. In this study, durable response was not associated with the definition of the viral remission by HBV DNA, and also there was no relation with the duration of unnucleosed analog viral remission, and also duration of consolidation therapy after e-antigen seroconversion was not associated with durable response. Another study, small study from Asia, reported that the patients over the age of 40 who received less than 15 months of consolidation treatment had higher virologic recurrence rates. Prolongation of consolidation therapy beyond 3 years decreased the risk of persistent virologic relapse and increased the likelihood of S antigen loss. In E antigen negative patients, the first study by Hadzianis and his colleagues reported the results of 33 patients who stopped adefovir after 4 to 5 years of undetectable HBV DNA. And during the first 3 months of adefovir, HBV DNA levels became transiently detectable in almost all patients. But at the end of year 6, sustained response was observed in 55% of the patients, and 39% of patients achieved S antigen loss. In the E negative arm of the systematic review that I mentioned for E positive patients, viral remission in E antigen negative chronic HBV patients was 30%, 36 months after stopping nucleoside analogs. And in this study in E antigen negative patients, 38% of 967 E negative patients had durably low HBV DNA levels with normal ALT, and only 2% achieved S antigen loss. An important finding of this study is durable response is associated with the duration of virologic remission on nucleoside analogs. They also examined the clinical events in patients with cirrhosis at baseline. Decompensation, jaundice, and death was very rare in the study. This is another systematic review only in E negative patients. Here the definitions differ compared to the previous systematic review. The virologic relapse was defined as HBV DNA over 2000, and clinical relapse was defined as HBV DNA higher than 2000, international unit, and ALT levels higher than the upper limit of normal. When we look at the relapse rates at year 1, virologic relapse rate was 70%, clinical relapse was 50%, and 40% of the patients required retreatment. And relapse rates were higher in patients with shorter treatment, shorter consolidation treatment therapy, and in patients treated with less potent nucleoside analogs. And off-therapy severe flares were rare. Hepatic decompensation was reported in only 1 patient with cirrhosis. Another Asian study which examined the apostle stopping rule, and this was a prospective study, found that the incidence and predictors of S antigen clearance after stopping treatment in E antigen negative patients was related to shorter time to undetectable HBV DNA, and also longer treatment duration, longer than 3 years, and greater reduction in S antigen level, and also lower end of treatment S antigen levels. And in this study, untreated relapsers had 7 times higher incidence of S antigen clearance than those who received retreatment. The role of S antigen in stopping treatment in an aging cohort is thematic review showed that off-therapy clinical relapse was lower in patients who had S antigen levels less than 100. And also off-therapy S antigen loss was higher in the patients with S antigen titers less than 100 international unit per milliliter. And FINIT study is a randomized control study which examined the stopping tenofovir and long-term response after stopping tenofovir and compared it with the patients who were on tenofovir during the same period. Here we can see that 21 patients stopped the treatment and only a few patients started treatment, and 62% of the patients remained off therapy and 43 had achieved S antigen loss or HBV DNA less than 2,000. This study also established the retreatment criteria in a very good manner, and which can also be a guide for us when we stop the treatment to start treatment to the patients. And also they examined the S antigen kinetics in stopping in patients stopping tenofovir. Here we can see that S antigen levels can decrease in patients who stop the treatment, but the patients who are on therapy show stable S antigen levels. Also, an Asian study examined the probability of S antigen loss after stopping entecavir, and they found that HBV genotype and viral antigen levels were related with HBs antigen loss. And the predictors of HBs antigen loss were low S antigen levels, less than 100, undetectable correlated antigen, and also HBV genotype C compared to genotype B. And non-Asian ethnicity was also a predictor of S antigen loss. I want to mention about the correlated antigen. Correlated antigen is a new biomarker which is also proposed by the Japanese guidelines and also incorporated into the guidelines. It shows the HBe antigen, core antigen, and also correlated protein. And it can be, in future, it can be a marker for stopping treatment. Here, we have challenges in interpreting these studies because of the heterogeneity of these patients, duration of consolidation therapy for E antigen positive patients, definitions of relapse, and also the criteria for retreatment. How should we follow these patients after stopping treatment? Especially in E antigen negative patients, ALT should be followed monthly in the first 1 to 4 months, and then every 3 to 6 months for 1 to 2 years, and afterwards every 6 months. HBV DNA should be followed every 3 months for 1 to 2 years, and then when indicated. In relapses, ALT should be followed every 1 to 2 weeks. If ALT is rising or more than 5 times over the upper limit of normal, bilirubin and prothrombin time should also be followed. And for retreatment, overt hepatic decompensation, persistent ALT elevation, or repeated clinical relapse, and high risk for the patients who have high risk for disease progression, and the patients under risk of HBV reactivation due to immunosuppression or chemotherapy should be retreated. In conclusion, patients with cirrhosis require lifelong nucleoside analog therapy. e-antigen positive chronic HBV patients can stop treatment after e-antigen seroconversion and after completion of at least 12 months of consolidation treatment. Continuous follow-up is required to assess viral, hepatic flare, and e-antigen seroreversion. In E-negative patients, S-antigen loss is the desirable endpoint. Stopping treatment can be considered after at least 3 years of continuous HBV DNA suppression. Close follow-up is required for viral and hepatic flares, and the patient should be informed regarding the potential risk of flare. S-antigen level may be used as a biomarker if available, but the cutoff is not clearly well known. Some studies found less than 100, and some studies found 1,000. And in resource-limited countries where there is limited access to HBV DNA monitoring, it still remains unclear when to stop therapy. Thank you very much for your attention.